residency at the same time, but he became a professor in Syracuse. So he's one of my protectors. You see how we act tough? And we have the other, my friend in Phoenix, he's a Bruce Lee martial artist and movie producer. So we have a lot of fun with the patients who visit us. Now, the integrity concept, Chris was one of the first surgeons, the only surgeon, that from the business leaders like Jerry Colangelo created a procedure they call Integrity Tiger. Integrity Tiger means you operate on a patient, you guarantee your results. So my son was the first surgeon we called an Integrity Tiger. So I'm going to summarize my 28-year experience conclusions, and that is, if you can do full endoscopic surgery under local anesthesia, no general, and just do decompression, and you have the least invasive, the safest, and the most cost-effective. Even more cost-effective than my second son, Mark Wang, because fusion and he uses all the expensive stuff. So I'm going to talk about my 28 years experience in a master talk, which I thank Dr. Yeung for inviting me every year that I'm here. But I can summarize. If I operate on you, I will have a 72% good to excellent result with modified McNabb. I have greater than 90% patient satisfaction. From the time I started in 1998, I have greater than 85% of my patients that don't need a fusion. So I'm going to take away some income from those of you who are dependent on fusion. My complication rate is less than 1%. And I continue to get better by stratifying my indication, meaning that as they get smarter, I tell more people to suck it up and forget about pain because you don't die of pain. So now I am publishing my 5-year results, but I really have 10-year results I can start to review since 2003. I use statistics called Kaplan-Meier survival analysis. I don't know if Mike knows about that. But if you do that, it measures the timeline of what you do and how long it lasts. You're all going to die one of these days, so it can never be zero. But if you very highly select, let's say my 95-year-old mother needs surgery, I can guarantee that they don't have to have a general anesthesia. I can do what I can to take care of the pain. We call that surgical pain management, not management, but care. So endoscopic documentation of what you do is going to be the key. That's why Stryker, I was involved with a company, they paid $500 million for just the chance of having the robot to teach you how to do endoscopic surgery. And when you do that, you look at the anatomy, you find that there are a lot of anomalous anatomic structures that's in the frame and that you never see, because when you do open surgery, you never see it. So this causes you to be disruptive. We have new evidence-based medicine, Cochrane, and evidence-based medicine consideration that's supported by endoscopic indications. So these are some of the anomalous procedures I see. You see all those nerves? Some of them are motor, some of them are sensory. But in the dorsal ramus, 90% are sensory. However, you can never understand 100% because there's variation. Here on the right, you have incidental synovial cyst that I saw through the scope that did not show up on the MRI. We saw an neuroma in the foramen that you cannot figure in the MRI. And if you operate, there is scar tissue that's symptomatic, that is not a disc herniation. Here's the scar. You take out the scar with a laser, the pain goes away. So it's not like doing everything that you learn traditionally. So sympathetic nerves, these are in the foramen. If you do a H&E stain, you can see there's ganglion. You don't have ganglions in peripheral nerves. The future is going to be that you correlate the pathophysiology with the pathoanatomy from neoplasm, trauma, degeneration, normal aging. So when you surgically treat the pain generator with surgical pain care, and if you have a robot to help you, then it's going to make an average surgeon much better because you have lots of aid. So it will decrease the impediments to work and recreation. It will decrease work disability. It will improve quality of life. And it will promote patient involvement in their own patients. And China is perfect for that because you have over 5,000 years of history, and patients will believe in acupuncture, they believe in Chinese massage, they believe in all these traditional procedures that help. And if you're treating pain, you don't have to worry. If they're happy, then I'm happy. But if they need to get more, then they can do endoscopic surgery. So when I do this, I do my own injections. And I take care of the people that you say are too young, too old, too pain sensitive, too high risk comorbidity, or too much of a bad attitude that I don't want to take care of them. So I only take care of the people that I select who pass my tests and I do my injections. So it's safer than traditional open surgery. Initially, I had 3.5% published complications in 2002. Now, I have less than 1%. And very seldom do I have any permanent residuals unless they have some conditions like fibromyalgia, have peripheral neuropathy. I think I have it. I'm 78. So how do I get it? I don't know. But when you live too long, your body starts to attack itself and you get peripheral neuropathy. So in summary, if you start with discogenic pain that's enhanced by evocative chromodiscography, if you treat herniated disc, contained, protruded, extruded, you stage your decompression. You use a laser to help you as a tool. It's expensive, but it's worth it, because I've been using lasers since 1998, and I got FDA approval. And then I do workman's comp, the people who are motivated to get disability. My results are much better than a person who goes to an open surgery, because the patient that don't like their work, they claim disability. So what endoscopic surgery does is to augment gold standard surgery with intradiscal therapy. It may require a change in traditional surgical indications. If you use the technique that I developed in 1997, then you're going to go after the source of the pain, the irritation, the inflammation, the pH of the disc, and replacing the nucleus, which I haven't finished because I was working for a company that had hydrogel for nucleus replacement. Hanson Ron believes we should be using silicone, but I think it doesn't matter. But if you can see what you're doing and you can treat the pathophysiology, the pathoanatomy, the pathophysiology, you can get a very good result, even though you don't cure the patient. So moving away from fusion, which is a little bit different than Dr. Mike Long, he's too busy looking at his computer. But you can eliminate fusion at least by 87.5%. So if you take care of your patient based on their age and their comorbidity, you stage your procedure, the body will take care of the problem over time, because the aging process will give you the result. So the key important factor is those who follow what I teach has to have appropriate training. And appropriate training means you need to be a surgeon who's a leader of the team. Okay? You have to use endoscopes, radio frequency, laser, dissection, decompression tools, and instruments. Now, eloquence is sold to Shanghai Kinetic. I hope they can carry it forth in China. And the doctors have to perform the procedure really well, like a professional athlete, like the dream team. So if Mike wants to join my practice with Chris, he will be part of our dream team from Florida to Arizona. We have dry heat, so it's not more comfortable, Mike, if you're listening. And I started learning because I learned from Professor Harry Kwok, who was talking about discogenic pain. He was a visiting professor at my residency. And then he actually visited my home. He and his wife, there he is in front of my house. And I started with camopapin. I still want to use it. There's a Korean doctor that used it a lot, but that is the beginning of intradiscal therapy. The initial studies of nucleus replacement began in China, starting with Replication Medical. I tried to buy the company from the CEO. She turned me down. Maybe I offered her, but maybe Shanghai Kinetic can get it for cheap because she's getting more desperate now. So intradiscal therapy begins in the disc. Foraminal decompression, either endoscopic, open, translaminal, different techniques, is the next step. The visualization of pathoanatomy, and then you can ablate the pain generator, dorsal rhizotomy. Tenzo Lee learned that from me. He's famous in China because he knows how to do rhizotomy. And then now you have hybrid procedure incorporating all three therapies. Okay? So I will acknowledge that Mike Wong and Chris are smarter than me. They know more. But I'm their father, so they have to pay respects. So I put a lot of my videos on Google playlists and on YouTube. It's banned by China, so none of you can have access to my videos. And the main thing is if you use the right radio frequency, eloquence, it's going to get you there safely. I've had no complication with eloquence. I use laser. There are different kinds of laser. I use the homeopathic. And if you compare line decompression using laser and without laser and compare it with endoscopic visualization, the results are 2 to 3 times better with visualizing the pathway anatomy. So here's what I know as I get older. What I think I know now is no longer valid or become disproven over time. So the integrity issue is if you warranty your results, at least you give your money back if they don't get better. There are a lot of unrecognized causes of failed back surgery. One is cancer. One is your body rejecting itself if it gets too old, autoimmune disease, fibromyalgia, all these unknown, undiagnosed comorbidities, which I think I have. So patient values are important. If your patient likes acupuncture, let them do acupuncture. It won't kill them. It's just for pain. But each patient and doctor brings a personal set of beliefs that what you do is what's best for the patient. And that's going to get you very far. Patient rely heavily upon your recommendation as your surgeon. If you let them know all the options and you treat pain, you say pain won't kill you, you may wish you were dead. But if you want to do it, I can do it for free or I can do it for whatever you're willing and able to pay. So the training is different, background is different, concepts are different, technical abilities are different. We are all different. Even our patients are different. So you have to know how to select your patient and get them for surgery. So what I am promoting is a full transfemoral decompression for endoscopic surgical pain care, not management. And you do it under local anesthesia, even without Espera, even without BMP, even without all the fancy implants. So, but I specialize just in lumbar because I haven't even continued, I haven't become the best that I can be, just stick in lumbar. But here, now, those of you neurosurgeons, they're learning to use the endoscope in the brain. So they're doing decompression for hemorrhage and things like that. They use high resolution disposable images. And in every country, especially in cash option, at Christmas we give out red envelopes. I mean, that's a nice tradition. You want the doctor to take care of you, you give him a red envelope. So you always give me Chinese tea, so you understand. So we're going to bridge the gap between prosthetic surgery fusion and endoscopic spine care. Is going to be bridging the gap toward the patient. So one of my fellows gave me this cap, mixed spine grade again. And I have a cap that said MAGA. You can't do that in the United States. So they say, you're terrible, you like Trump. I said, no, MAGA is make Asians great again. He said, okay, I accept that. Thank you.